short delay there. My sincere apologies. We're not really sure why we're having so many problems today. Okay, so we were actually fairly split in terms of who knew what a PICO was and who that was new for. So let's just look at that for a moment. So PICO is a way to actually define quite specifically what our issue is, like a practice-based issue that we might be dealing with. And the P stands for the population, or if you were dealing with looking for qualitative data, the P would represent the situate, could also be thought about as the situation. Population we can use as well with particular quantitative research. The I stands for intervention, or it can also be turned into an E if we're looking at the relationship between exposure to a risk factor. For example, it could be poor housing and that relationship with a health outcome. C we sometimes use reflects comparison. So what are we comparing that intervention to? Is it the standard practice, or is it nothing at all, or another type of intervention? And then finally, O reflects the outcome. So what are we specifically interested in looking at the impact of an intervention on? So PICO can be very helpful in terms of moving from knowing that there's an issue that needs addressing, let's say at a community level, and then before going and searching for evidence to address that issue, a PICO lets you really define quite specifically what it is you're hoping to find. And then sometimes we might include an F, which could be a particular setting we want to know that about, or it could even be a T, which is a time frame. So we might want to know what the outcomes look like 6 months later after the intervention's completed, or 1 year later, or even longer term. So just a nice way to think about what the intervention, what that issue question is all about. So for today's review, the population is all populations from any region of the world and from both industrialized and non-industrialized countries. And it was including all housing types except mobile homes, and it was any type of intervention to improve for home improvements, although that did not include reducing lead and or radon, but any other types of interventions involved in improving housing. And it was not compared to head-to-head comparison with any other intervention. And then the outcomes that the review focused on were direct measures of health or mental and physical illness, general measures of self-reported well-being, and quality of life measures such as health service use was not included in the health outcomes. Our secondary outcomes were additional social and socioeconomic outcomes, including fuel costs, household income, measures of social contract, social exclusion, education, employment, and time off work. And then just at the bottom there, you can see quality rating 10, which equals strong. So on health evidence in the registry, we assess the methodological quality, as I indicated earlier, and this review received the highest rating that it can get, a 10 out of 10. Okay, so I'm now going to move the speaker over to the mic over to Hilary Thomson, who's a senior investigator scientist with the MRC CSO Social and Public Health Sciences Unit at the University of Glasgow in the United Kingdom. And so we're just moving the mic over to Hilary.
Okay. Yeah, okay, thanks very much, Maureen. Now, do I have... Do I have control over the slides here? Yeah, I do. Yeah, great. Okay, so that's me. And thanks very much for the invitation to speak to the webinar today. I've never done a webinar before, so it's a bit bizarre sort of talking about an audience in front of me. Oops, there we go. So the review asked the question, what do we know about housing improvement and the health effects that you might see following housing improvement? So, as Maureen said, it was a systematic review, and we didn't just look at the health effects, we also looked at socio-economic impacts of housing improvement. And this review, the full reference for the most recent version, is available on this slide with a link. It was published as a Cochrane collaboration review and a CAM at the beginning of last year. So, first of all, what we did was we took a very broad approach. So, some of you who might have some sort of experience of looking at systematic reviews might think, oh, you take a very narrow approach and you only include randomised controlled trials and certain outcomes. And to some extent that can be true in that you have to define very carefully what you include. But we took a very broad approach to our review, and we didn't just include randomised trials. We also included quasi-experimental or controlled and uncontrolled studies. We also included qualitative data, and we didn't just look at health outcomes, we also looked at socioeconomic determinants of health, so things like changes in employment or income or educational outcomes. We also included, I'll talk a bit more about the study designs and how we use the qualitative data later on in the presentation. So the systematic review, we searched very widely across 59 databases, and we were to include studies from anywhere in the world in any language. And then once we identified the studies, you can imagine there was a very broad range of I'll speak closer to the mic, hope that helps. There was a very broad range of interventions that we sort of came across. So we tried to group them as appropriately as possible. And the 4 groups that we ended up with were warmth and energy efficiency improvement, all after 1985, housing-led neighbourhood renewal, so that included programmes of regeneration and retrofitting since 1995. And then there was a group of studies, a small group of studies from low and middle income countries and provision of very basic housing improvements. And then some very old studies from pre-1960, which again were kind of providing fairly basic housing requirements. And then when we synthesised the evidence, we drew the conclusions prioritising the better quality evidence. And that's a key part of any systematic review, is that you assess the quality of the evidence in each study. And then you don't just sort of treat each study the same, but you prioritise the evidence from the better quality studies. So what we found from these wide searches that we did was huge. As you can see in this flowchart here, nearly 60,000 records were screened following the searching. So we spent quite a few days going through thousands and thousands of records. And the reason that, we cut it down to 336 full text articles that we looked at in more detail was that because of all the different things we were interested in, the searches had to be very sensitive. So we had to, allow ourselves to find lots of things that we could immediately say when we looked at them, well, these aren't very relevant. So it wasn't that we were excluding studies of housing improvement. It was that they were obviously not relevant when we looked at them in terms of the abstract. So at the bottom of the flowchart, you can see then what we included in the review. So, and we've grouped it by the quantitative and qualitative studies, and also by the group of housing intervention type. So you can see that most of the studies were quantitative, and they were about warmth and energy efficiency measures, or rehousing or neighbourhood renewal. And then there were a couple of studies in these other categories. And I'm only going to talk about the warmth and energy efficiency measures and the rehousing and neighbourhood renewal programmes today, because that's what's probably most relevant to this audience, I'm imagining. And also because there was such a small and quite poor quality body of evidence from the other categories, I'm not going to talk about it today. And then there were some qualitative studies that we tried to incorporate into the synthesis overall. So, here we go. First of all, just for those of you who are not that familiar with different study designs, I'll try and sort of describe these briefly for you. So ideally, when you're measuring effectiveness, you really want to have a randomised controlled trial. And this means that you would get a group of individuals who are eligible for the housing improvement, so they have an equal eligibility. and then you randomly allocate them to whether or not they get the housing improvement or not. Now, you might think this would be absolutely impossible with housing, but it has actually been done. I think we found about 5 randomised controlled trials. And so what happens is that, as you can see in the top pictures, the people that are randomised to receive the housing improvement move from their old house into their new house, and you follow them up. So you would assess health at baseline when they're still living in their old house, and then you would follow them up in the same time of year, a year later, and maybe subsequent years after that even, and see if their health had changed. And then the group of residents who were not randomised to receive the intervention, you do the same. You assess their health when they're in their house at the same time as you're assessing the health of the intervention group. So that's the intervention group of the people who are moving. So, and you assess their health a year later as well. So you're sort of trying to keep everything as similar as possible. But the justification for being able to randomise in something like housing improvement is that you can't give the housing improvement to everybody at the same time. So you basically randomise by waiting lists. So you randomise people who get the housing improvement first. And then once the study is over, the people who were due to move in the second sort of phase of the housing development can then move into their new house. So that's a way of doing a randomised controlled trial of housing improvement. But often, as you can imagine, that's not really possible, or certainly it can be possible, but it's a very difficult thing to do. So often what we have in terms of looking at health effects of housing improvement is what you would call a controlled before and after study. So this is where you also have a control group and an intervention group, so that you can compare between the two groups. But the groups are not randomised. And again, you're assessing the health before and after the people have moved and trying to assess them at the same time point. The difficulty with controlled before and after studies is getting a control group which is genuinely similar to the intervention group. Because often the people who are selected for the housing improvement are selected for that improvement for a reason. And the most likely reason is that they have a greater need. So there's quite an important reason why the intervention group will be different to a control group, even if on quite broad socioeconomic indicators you can see that they're quite similar, but there probably will be quite a systematic difference between the two groups. And that's something that's quite difficult to control for. But that's the benefit of a randomised control trial, is that the randomisation allows you to control for that because people are randomly selected to receive the housing improvement. So, and if you might think, well, that's fine, let's just look at control before and after studies. But as you can see, it's difficult to get a control group that is really genuinely the same as the intervention group. And also, it can be difficult just to recruit a control group, to get people to take part in a study. Then they think, well, why would I bother? Because, there's nothing really in it for me. I'm not going to get a new house at the end of this study. So sometimes people will just do a before and after study, and they'll just look at health when people are living in their old housing, and then follow them up a year later and look at change. And the obvious difficulty with this is that you don't really know why health might have changed afterwards. You don't have any comparison or counterfactual with which to compare it. So, yeah, you can't really control for the other important changes which might influence health, and you don't really know if health would have changed anyway, or whether it's attributable or due to the change or the improvement in housing condition, because there's lots of other influences on health that we can't control, like changes in neighbourhood, changes in income or state benefits and welfare, or changes in the amenities that are available to people locally, and just changes in individual circumstances, whether or not people have lost their job or been promoted or somebody's taken on. So that's a bit about the different types of study designs that we looked at. And in the synthesis, most of the studies that we looked at were randomised trials or controlled before and after studies. So I'm going to talk now a bit about what we actually found. And first of all, I'll talk about the warmth and energy efficiency improvements. And as I said, a systematic review should look at the quality of the studies and prioritise the conclusions of the review based on the quality of the studies. So we assessed all the studies for potential biases or quality. And the sorts of things we looked at were how comparable was the control group, and how did the analysis maybe try to control for some of these additional changes that might have happened. Or another thing that we looked at was how many people kept with, stayed in the study right throughout. If only 50% remained in the study at follow-up, then you've got quite a risk of having bias in the study, that the people who didn't benefit actually withdrew from the study, and so that would then affect your conclusions in the study, and it might bias the result. So in terms of the warmth and energy efficiency improvement, the studies that we found that were what we would call the best available evidence were a mix of 5 randomised trials, 5 controlled before and after studies, and one uncontrolled before and after study. And there were 4 other studies that we found that we graded to be at a high risk of bias, and we didn't include them in the synthesis. The types of interventions that these studies covered were quite diverse. Even within a single study, they were quite diverse. So people were given loft or cavity wall insulation, double glazing, central heating, lagging, fluid heaters or energy advice. And just seeing that there's a comment about it's difficult to hear me, so I'm trying to be as close as possible to the mic. Okay, I'll keep going at the moment. So, in terms of the findings from these warmth and energy efficiency improvements, the findings in terms of health effects were really quite mixed across the studies. There were some improvements in mental health, respiratory health, and general health. But like I said, it was mixed across the studies. Some studies reported quite sort of important improvements and statistically significant improvements in respiratory health and general health, but other studies didn't. And when we looked at the data in more detail, the greatest improvement was seen in randomised trials in New Zealand, and the least improvement was seen in UK studies. And the difference between them, when we looked at these in more detail, the difference between these 2 groups of studies was that in New Zealand, the studies had targeted people with respiratory illness who were known to be living in cold housing and poor housing. Whereas the studies in the UK used interventions that were delivered across a whole neighbourhood or whole area, and they didn't target just people with existing illness. The improvement was delivered to the general population regardless of their existing health conditions or illness conditions. So what we concluded from these data and the findings was that warmth improvements can lead to health improvements, but not always. So you can't always assume that if you improve people's warmth that it will lead to health improvements. But it's most likely that you will see health improvements if you target the housing improvements or the warmth improvements at people with existing chronic respiratory disease and who are known to live in housing with inadequate warmth. There are also problems here that have been seen in some studies, is that it's all very well to deliver a housing improvement to somebody like new central heating, but if they don't actually use it, it won't obviously change their housing condition. So it's quite useful to look at implementation. There were other effects or impacts or changes in outcomes that were reported in the warmth and energy efficiency studies. And these included things like reduced time off work or school due to illness, in particular respiratory illness, increased usable space in the home, and this was linked to improvements in household relationships and people saying that they could invite friends and neighbours into the house to entertain them. People said that they had increased control over the home environment. Some people reported reduced fuel costs due to the energy efficiency measures. And very often there were increased rent costs. But certainly in the studies that we looked at, the people who had increased rent costs were also dependent on welfare. So they didn't actually have to pay more rent. It was covered by the welfare provision. And so when we look at these outcomes, these are more like proximal outcomes. We wondered whether or not these might be mechanisms that might point to health effects later on. So then if we look at housing-led neighbourhood renewal programmes, so these are things like I'm not moving the microphone. I've moved a wee bit closer to it. I don't know if it's made any difference, but anyway, sorry. So if we look at the studies that looked at housing-led neighbourhood renewal, so all the studies that looked at this were from the UK, and there were 6 sort of what we would call best available evidence. So these are studies that we considered to have a level of bias that we still thought was able to draw conclusions on, and we treated it as the best available evidence. And the types of programmes that this included was something that is reasonably common in the UK, where whole areas of that are known to have poor housing and poor services and low-income groups and predominantly social housing are kind of often sort of flattened and demolished, and new housing is built. But not all the programmes were like this, but they were all area-based programmes. And when we looked at the studies that, as I said, health effects after people moved into the new housing or had a major renovation, there were very unclear health effects across the different health measures. And there was very little indication that health improved. None of the changes were statistically significant. But the things that were reported in the qualitative data were quite similar to the sort of things that were reported in the warmth studies. So things like increased usable space, increased control over the environment, reduced fuel costs. So why were these things not leading to health effects? So kind of thought a bit more about, what's the difference between the warmth programmes and housing-led regeneration. And I think the thing it comes back to really is the fact that some of the warmth studies that showed the health improvement were much more likely to be targeted according to individual needs, both in terms of health need and housing need. And so there was a much greater potential to benefit across the whole sample. And this compares with the sort of area-based programmes where the intervention itself was much more diverse. It probably included warmth improvements for most of the people, but we don't know because the interventions weren't very clearly described. There was probably a lot of other disruption going on within the neighbourhood. People might have had to move out their house while their houses were being renovated, and there was probably a lot of neighbourhood change going on. And also, the intervention was delivered across whole neighbourhoods, regardless of individual need. And I think that means that the potential to benefit for individuals wasn't consistent across the whole sample because we weren't targeting individuals with specific needs. So it may well be that within these studies, in sort of whole samples, the mean is concealing an effect for those who did benefit. So you might not see an effect, but within that study population, there may well have been a certain group of people who did experience health improvement that was attributable to the improvement in housing that they experienced. And another question that we asked, because I've presented this work so many times, and I'm always so sort of disappointed or frustrated that I can't just stand up and say, yes, it's wonderful if you invest in housing, you'll see health improvements. And we wondered why you weren't seeing such big health improvements following what is potentially maybe quite a big improvement in somebody's life. And there's, I think, quite a lot of different things that might explain why you're not seeing a dramatic health improvement following housing improvements. One of the reasons is that the evaluations are really very short term. They're only looking up to 1 year to 2 years. And maybe it's very unrealistic to think that, you know, moving somebody on who's already sort of in a socioeconomically deprived situation with poor health, that their health will improve in a, you know, in a very short period of time. And maybe the rationale for improving housing beyond energy efficiency and a social justice issue is more for improving the health of future generations who live in these houses. Another issue is that we don't really know to what extent there were tangible improvements in a lot of the studies in terms of the actual housing conditions. One of the studies that we carried out ourselves, when we asked residents at baseline what their housing condition was like, although their housing didn't look very nice, they didn't report many problems with dampness or cold or moisture. So, you know, it might be that some of these programs of housing improvement are delivered for reasons other than really just to improve the high sort of warmth conditions of a house. So we don't know whether the baseline conditions of the house were actually affecting the health of residents. And another explanation is that housing and health has a very complex relationship. And when you change something like housing, you might be seeing other sorts of changes that might then affect health. And that might counteract the potential of the improved housing to affect health. And one of the studies that we discovered in the sort of slum, the historical studies, that I think has got quite a useful lesson, when they rehoused people from Newcastle in the UK, from slums to modern self-contained housing, and they followed up people for 5 years and they had a control group, they found that mortality rates had increased in the intervention group. So people who'd moved to the better housing from slums were actually experiencing a much higher mortality rate, which seems completely counterintuitive when the mortality rates in the control group and the comparison group hadn't changed. And when the researchers went back and looked at this in more detail, they found that the people that had moved into the new housing had had their rents doubled. And they reported that they weren't able to buy sufficient food to feed themselves. They were prioritising their family. And that was used to explain the possibility of why you were seeing an increased mortality amongst this group, despite moving into better housing. So there are other factors that go on that might be associated with housing improvement and that might counter the potential for the housing improvement to actually lead to improved health. And another issue, which isn't really discussed that often, is that housing is only one factor in the link between poverty and poor health. And perhaps as well, it's not really as strong as it's often assumed. So when you look certainly at British data, there is a link between poor housing and poor health. But when you start to control for other socio-economic variables, the link is maybe not as strong as we might have thought. And also, if you're only, this is a bit like we expect to see health effects in the short time scale of an evaluation. By addressing one factor that is to do with poverty, are you really expecting to see improvements in health if the person is still without a job and on a very low income? Okay, so finally, I'd just like to talk about proxy measures of health. As I mentioned, that we didn't just look at health impacts, we also looked at socioeconomic impacts. And the reason for that was, it's all very well saying, you know, housing improvement is linked to health, or housing is linked to health, and so therefore if you invest in to improve housing, you'll see improvements in health outcomes. So on the right-hand side of the slide, I just used pictures to try and illustrate examples of improved health outcomes, like healthy child outcomes, reduced obesity, reduced smoking, and healthy lifestyles, and then living to a healthy old age. But actually, we need to think a bit more carefully about the theory about why is it we think that improving somebody's house would lead them to, say, for example, lose weight, do more exercise, reduce smoking, have healthier children. And we don't know an awful lot about this, but we used the data from the review that we had to try and think more about this. And the reason that we did that is that if you look at these proxies, so the impacts on socioeconomic determinants of health, they might be much more likely to change in the short time scale of an evaluation. So that's why we call them proxy, because they're proximal impacts. And it also maybe if you can detect changes in these proxy measures, then it might be that you can at least say, well, it does point in the right direction, and it does suggest that there might be potential for longer term health effects. And also, as I explained with the example of the doubling of rents and mortality, is that they might act as mediating factors, and they might help to explain the absence or presence of health impacts that you're seeing. And by identifying that, it might be an important sort of identification of how you can maximise the potential for something like housing improvement to lead to future health improvement. So what we did now, this has not come out well, and I can see it's not really suitable for a slide like this, but we basically mapped out all the data that we had to try and develop a theory that was based completely on the empirical evidence and the theory of how housing improvement might, over time and through these pathways, lead to subsequent health effects. And if anybody is interested in this, I'm happy to send you copies of these models that you might want to look at in more detail, because they draw a lot on both the quantitative, well, they draw completely on the quantitative and qualitative data, but most of these the data on the proxy measures and the non-healthy measures really come from the qualitative data. And in summary, the sorts of things that we concluded were sort of potentially important proxy impacts of housing improvement that might lead to health effects were an increase in domestic space and design, although it might not always be an increase because there are some elderly people that moved to a smaller house and found that much more affordable to heat. So it was about providing domestic space and design that was appropriate to meet the needs. And I think, as I mentioned before, there were other people who said that because they could heat the whole house, because they could afford to with the new measures, that they were able to use the house a lot more. So there was a much greater space for people to use. And then they said that we're getting on as a family a lot better because we're not all sitting in the one room at night fighting over the remote control for the television. And some people reported that they were able to go to their room and study. So that was seen as an important proxy measure. Also, improvements in thermal comfort might lead to improvements in respiratory health, reductions in housing costs, then impacts on disposable income, which people did link to if they had more money, being able to spend more money on food, although it might not always be healthy food, or they might choose to spend on cigarettes or something. And also people reported having greater housing satisfaction and control over the living environment. And these are things that you could potentially link to subsequent health effects. So these aspects may act as mechanisms through which housing improvement may or may not lead to longer term health effects. So in conclusion, the conclusion of our systematic review really is that improvements in warmth can lead to health improvements, but it can't be assumed, because if you remember, the studies in New Zealand did show improvements in health, and they were very rigorous randomised studies, but the data from the UK was less conclusive. But it is important at least to know that there is no evidence of harmful effects. The greatest potential for health improvement is where the improvements are targeted at those really with most need in terms of health and housing. And in terms of the area-based programmes, it's very difficult to tease out health effects from there, and I think it's because the interventions themselves are quite diffuse. And then also, as I've just been talking about, there are proximal impacts that may be mechanisms through which housing improvement might lead to longer-term health impacts. And so our conclusion really, in terms of an applied conclusion, was that healthy housing investment should aim to provide affordable thermal comfort in housing of appropriate size and design needs. So that's me finished the formal part of the presentation. I'll switch over. Do I need to do anything?
That's okay, Hilary. Thank you very much. We're just switching over back to me, and we'll be. I think we've now muted your mic.
Okay.
So just bear with us for a moment here as we mute your mic. Can you just say one more comment, Hilary? All right. Okay. Now I see that you. Now I see that you're muted. Okay. So thank you very much, Hilary. For those of you that joined us today, this was an extremely complex review. And many studies and many hours of Hilary and her team thinking about how to make sense of this very diverse type of evidence of varying qualities, and how to actually do justice to putting it into actually here a relatively small number of slides. And certainly thank you, Hilary, for offering to send to folks that would like to see the pathways, so that very nicely filled in logic model. There's actually a number of those in this review, looking at the data and the evidence from different points of view that might be useful. And so certainly we can help facilitate access to that if any of you would like those. So the slide that I have up, just before we open it up to questions for Hilary, is again just bringing us back to, you know, thinking about evidence-informed decision-making. So what Hilary has presented for us today really is a representation of what currently existed in the literature as of 2013 around housing improvements and its impact on health outcomes. So that really constitutes that purple oval in our model here. And certainly in terms of thinking about how you might be then applying this evidence to practice would be then for your own areas, whether that's a community level or regional or municipal or regional health areas, or provincially or even nationally, thinking about what the community health issues and the context are, particularly around even knowing data like who is currently in poor housing and has a chronic condition, for example, if one were thinking about focusing on interventions for that group. What are the community and political preferences and actions, which may or may not differ from community to community? And then what are the resources? And perhaps here, it's not so much just public health resources, as in a number of jurisdictions across Canada, funding for housing would likely fall outside of the realm of public health funding. And so this would be across multiple government sectors. So what we might just want to be labeling that as resources to put towards these types of interventions. And then thinking about and then using our public health expertise to make sense of all of that evidence around how to then either move forward or not with programming around housing improvement. So just thinking again around where this scientific evidence that's both quantitative and qualitative would fit into a much more complex decision-making process. So with that, I'm actually going to just turn it over for questions and see if any of our participants have questions for today. And while we have the opportunity of having Hilary on the phone with us what type of questions you might have for her. So if you please, just a reminder to use the chat function and to chat all, not to the host, then we'll all be able to see the questions coming up. And then you'll also see them as well, Hilary, but I'll turn the mic back over to you to address particular questions. So I'm just giving you a moment if some of you are typing in any questions for them to actually show up. And I'm not seeing anything. So Hilary, I might ask you a question while we're waiting for some additional questions. One of the topics I didn't see you talk about today, which doesn't mean it wasn't addressed in the review, is whether or not there are any differential impacts of these interventions by ethnicity, and whether or not you're able to comment on whether these interventions might work better or less so with different type of ethnic populations. So I'm just, bear with me, we're just turning the mic over to you, so go ahead, Hilary.
Okay, thanks, Maureen. Well, we did look for any data from any of the studies that look at differential effects for different groups. So that looks like ethnicity, gender, can't remember anything really, any differential effects. But we didn't, well, there was very few studies that actually looked at differences in effects by group, and there wasn't enough to make any conclusion about it. There's Julie Scarpino, but I'm not sure if that's a question or just a report of your experience. So Julie's asked if there were any housing bylaws in the studies. Well, there weren't any reports of anything like that. Do you want to give an example of what you might mean by that?
There's another question that has come in, but we see that Julie has responded. So Hilary, will let you respond to that before we go to the next question. So if we could unmute Hilary.
Thank you, Maureen. So housing legislations that require housing to a minimum temperature, there weren't any studies that reported anything like that. And if you're from Canada, I've heard that there is something like that in Canada, but I've not come. I mean, none of the studies came from Canada.
Great, thanks, Hilary. And so we just have another question that was asking, was there any differential in interventions related to whether intervention housing was in rural areas with single dwelling or in densely packed urban multiple dwelling units?
Most of the studies were from urban areas, but there were some studies of warmth that were from rural areas. Trying to think off the top of my head. There was certainly one that was from a rural area. Yeah, it depends, I suppose, how you define rural, but they certainly weren't all from the inner city areas. But we didn't do analysis looking at comparing these groups of studies. Maybe we should.
Thanks, Hilary. And I guess, again, one of the challenges is if you only had one or two studies that were, and if they were small and if they had some limitations, then that would, be quite complicated in terms of then doing some separate sub-analyses just with those studies.
Yeah, I think there probably weren't enough studies and enough information about the context to really justify that.
Right. So we have another question here that is from Jennifer Stewart, just asking, proxy impact is a new term for me. Can you explain?
Okay, so proxy is just a short name for proximal. And I'm sorry if it was confusing. I forget, I'm used to using the term. So proximal just means like near, and distal would be far. So proximal I was using to mean that these might be impacts that happen quite soon after the housing improvement, whereas the health impacts might be something that are distal or much further down the line. But that the proxy measures, you can use them as a proxy because they're acting on a determinant of health, and so you can't conclude therefore that you'll see health impacts, but it can help you to think that it might point to the possibility of health impacts. So if you think about the sort of the logic model with the photographs and the housing improvement on one side and the health outcomes on the other side, if you do at least see changes in intermediate outcomes or proxy outcomes on determinants of health, you can say, well, that might be a proxy for longer term health effects. Does that help?
And then we have an additional question from Christina Nairn that says, I'm wondering about your thoughts regarding any research of health benefits based on housing first models that have a supportive housing component as well as stable housing. Sorry, just let me finish. The supportive housing component where individuals receive supports or services as well as stable housing.
Well, we only looked at studies that were improving housing, physical housing conditions. So we didn't really look at supportive housing studies unless they specified that people were also moving into a physical house that had improved physical conditions compared to what they'd been experiencing before. So I can't really comment on that.
Okay. Thank you, Hilary.
And the aspect of stable housing, I presume, is more about moving, like getting people from a sort of homeless situation or borderline homeless into more permanent housing. Again, we didn't look at that. Yeah.
Okay, I think we've actually. We have actually asked. Just trying to make sure. Yep, I think we've addressed all of the questions that you had, Julie Scarpino. And I have questions in a couple of different places, so I'm just looking. And so I'll just ask at this point if there are any additional questions for Hilary while we have her on the call. Just send those in. So, well, Hilary, I guess I might ask you one more question. So if you're thinking of you're at a health department and you know there are some issues in your community, and you want to engage your regional council in thinking about housing improvement interventions, you know, what approach would you take to that based on this evidence?
I don't like that question. It's too difficult for me. I suppose, you know, if you're talking about wanting to see health effects, then you would want to know what's the condition of the housing. Are you going to see actual tangible improvements in people's housing? And are the people living in what is known to be poor housing known to have poor health? But when I talk to like policy and practitioner people, you know, they get quite sort of dispirited by me saying, well, we don't really know very much about the health effects of housing improvement. But I often then say, but that doesn't mean that you shouldn't be investing in housing, because health's not the only reason to invest to improve people's housing. There are issues of just, you know, improving energy efficiency and reducing costs. There are also issues of social justice about providing good quality shelter. And there are also the whole other issues that I talked about, why these studies might not be able to detect the health effects. And it might be, for example, that the health effects that you might be expecting are far beyond the timescale of an evaluation. So I certainly wouldn't discourage decision makers in putting money into improving housing. But if they were really wanting to see health impacts of it, I think they would need to find out a bit more about, or be clear that they really are improving the condition of housing and that the people that they're targeting have chronic health problems.
Great. Thanks very much, Hilary, and thank you for letting me put you on the spot there. I know that was a really hard question. So I haven't actually seen any other questions come in. I'm just doing one
There's one question about how to get copies of the logic models, but I assume that we can sort that out between Maureen and me or Yassel.
Okay. Yes, we will sort that out. So thank you very much, Hilary, for joining us today. This really was very informative and wonderful to have the first author on this review present this evidence as opposed to the health evidence team. There's just so much thought and energy that your team has put into really thinking about what one can say about this evidence. It was really wonderful to have you with us today.
Thanks.
So I just want to finish off. I have two polling questions for those of you on the line. The first one is, did you find the information presented today helpful? And I'm just going to let you respond to that. And then we have one additional question before we end off the webinar. And so I think we're just going to move on. Thank you for responding. And more than half of you said yes to that. And then just moving on to the next question. Just give me 2 seconds here while the data is being tabulated. And the next question just asks is, was the information presented new to you? And we always find this is an interesting question to ask because for some of you, this will be new information, and for some of you, you may have already been aware of this information. And I think both of those scenarios are actually quite positive in that for those of you for whom this was new, wonderful that this webinar provided that new information. And for those of you who are already aware of this, this also could be just confirming the types of research that you had looked into before and helpful. And so for the majority of you, you did say that this was new information. So those are all of the questions that we have. Those are the final questions. You have our contact info at info@healthevidence.org. We will be posting the materials from today's webinar and the audio file by the end of today will be available if there was you wanted to go back in and listen, or if you wanted others at your organization to also take a listen, and also where you can go to access that information, just keeping in mind that you will have to log into Health Evidence, which will require a username and password. And so if you haven't done that before, just becoming a registered user, or if you've forgotten, then that will get sent to you. Okay, so I see that we're a few minutes ahead of time. So on behalf of Health Evidence and Hilary Thomson, thank you very much for joining us today, and hopefully you'll join us in the future for additional webinars. Thanks very much and have a great afternoon.